Good morning. Professor Rizzo apologizes to not be with you today. In high pathological myopia, the retinal detachment, the posterior pole, are most commonly due for the macular hole and occasionally for paravascular break. Probably in pathological myopia, the change that of the atrophy of the chororetinal may be the cause of the formation of the posterior breaks. And the localization near the vessel can be explained by tangential traction induced by the vessel too. Many surgical approaches have been established during the year for the management of this kind of retinal detachment with not a complete a full rate of retinal resolution, the retinal detachment resolution, and with some side effects. In our experience, we are now trying to operate 9 eyes of 9 patients with high myopia with posterior retinal detachment due to paravascular breaks. Implanting an autologous ILM prevail harvest for the posterior pole, not applying argon laser around the breaks, and using a light silicone oil for 2 months. Why to use the autologous transplantation of ILM? Because he created a bridge for the proliferation and migration of the glial cell. Has been explained that the use of silicone oil of the gas tamponade can be an adjuvant effect for the migration and the proliferation of the glial cell. The plug can form a scar reaction, and the scar reaction can be a physical barrier for the pass of the fluid through the break for the posterior part of the retina. We know that this plug can induce a retinal fibrosis that it can be a problem when we implant in a macular hole, but can be adjuvant effect if we are talking about not posterior, a posterior break, but not a macular break. So this is the first cases. As you see, a paravascular break in the nasal part of the retina, PFCL to protect the posterior pole of the macula. With the dyeing, we are searching for the best place for the ILM to harvest. This is the plug of ILM that we harvest not in the macula, and we put inside the paravascular breaks under the PFCL. This is the time of the silicone oil extraction. As you see, a complete retinal resolution, retinal detachment resolution. You can see the image on the left during the surgery, image on the right under silicone oil after the surgery when you see the blue ILM plugs, and then the images of CT after the silicone oil removal. Second case, total retinal detachment, macular hole, and plus we can see during the surgery paravascular breaks in the inferior arcades. We remove the ILM, as you see the paravascular breaks staining with the dyeing, with the vital dyeing. Inverted flap inside the break, inverted flap inside the macular hole. No laser. This is after the surgery, at the end of the first surgery. Fluid air exchange. And laser only in the 360 degree in the peripheral part, and silicone oil. The same image, as you see under the silicone oil, the right image, as you see the double plugs in the macular hole and the paravascular breaks, and the OCT after the silicone oil removal after 2 months. So we know the ILM autotransplant has demonstrated good results even in the myopic macular hole. We know that ILM autotransplant can induce a fibrosis inside the hole. We know that it is an undesirable effect if we are talking about the macular area, but it's useful to create a stronger adhesion in the retina without visual losing acuity and extrafoveal breaks. Thanks for your attention.
So congratulations, Tommaso. In the first case, did you remove the subretinal fluid and through the retinal tear, or you performed a retinotomy in the periphery?
No, we have performed a retinotomy in the periphery to not use the, because we have to working in a dry retina to put the plaque of ILM inside, and the majority of the cases we dislocate the fluid, the underretinal fluid, with the PFCL in the periphery, and then remove with the little retinotomy.
One question. Would you choose this technique when you have the atrophy of the choroid and you see the sclera down, or you will choose this for every break in a high myopia? Because I found this really useful when you cannot do laser because you don't have choroid in the atrophy.
Yeah, we have used it in the atrophy.
Yes.
All the 9 cases had the perichoroidal atrophy, posterior atrophy, and posterior retinal breaks. That we know that the laser with the RPA atrophy, have no effect.
Thank you for this.
Thank you very much. I think ILM flaps are taking over the world.